Hello everyone and welcome to the third session of the TRT World Forum 2020. I'm Oscar Sabakti, anchor of TRT World's international business program, Money Talks. I hope you've been enjoying day one of the forum so far. We'll now be taking the discussion further with this next session called What's Next? Understanding Health Threats in Times of Hyper-Globalisation. The global pandemic has made the world acutely aware of the strengths and weaknesses of public healthcare systems around the world. Some governments have been better prepared than others, quicker to respond, have taken the threat more seriously, and have also helped nations that were less prepared. This session explores the challenges of public health in light of the COVID-19 pandemic, examining issues around biopolitics, international healthcare cooperation, and the challenges of globalisation. To begin our discussion, let's hear from Tedros Adhanom Ghebreyesus, the Director General of the World Health Organization. Dr. Tedros was elected to lead the WHO in 2017 and is the first African to do so. Prior to this role, he served as Ethiopia's Minister of Foreign Affairs from 2012 to 2016 and Minister of Health from 2005 to 2012.
Excellencies, dear colleagues and friends, the COVID-19 pandemic has shaken the foundations of social, economic, and political security. Health systems are now facing a triple burden: to respond to the COVID-19 pandemic, to sustain essential services, and hopefully soon to mount unprecedented vaccination campaigns. But the challenge of equitable allocation of vaccines is one that transcends national borders, just like the pandemic itself. Equitable access is in the national interest of each and every country. In our interconnected world, if people in low and middle income countries miss out on vaccines, the virus will continue to kill and the global recovery will be delayed. Vaccine nationalism will prolong the pandemic, not shorten it. And while a vaccine is needed urgently to control the pandemic, it will not fix the vulnerabilities at its roots. There is no vaccine for poverty, hunger, inequality, or climate change. We need a radical shift in the way we identify and manage health threats and the factors that drive them. The United Nations was born 75 years ago from the realization that global cooperation is the only real alternative to global conflict. In the same way, the only way for countries to protect themselves against pathogens that know no borders is to work together. The COVID-19 pandemic must mark a turning point in leadership, solidarity, and governance if we're to protect our families and communities, as well as our economies, from the health emergencies, both present and future. I thank you.
Thank you to Dr. Tedros, the Director General of the World Health Organization. Well, to discuss these issues and more, it is now my pleasure to introduce our panel of esteemed speakers. Mehmet Oz is a cardiothoracic surgeon and the Emmy Award-winning host of the Dr. Oz Show, an attending physician at New York's Presbyterian Columbia Medical Center. He has authored over 400 original publications, book chapters, and newspaper columns, as well as medical books, and he's also received numerous patents and still performs heart surgery. Neil Squires is the Director of Global Health at Public Health England. He's the former Head of Health at the UK Department of International Development and is Visiting Professor of Global Public Health at Lincoln University and Board Member and Chair of the Governance Committee of the international NGO Malaria Consortium. Jamila Mahmud is a special advisor to the Prime Minister of Malaysia on public health. She is also a member of the Malaysian government's Economic Action Council and is actively engaged in the country's COVID-19 response. Prior to this, Dr. Mahmud served as Under-Secretary General at the International Federation of Red Cross and Red Crescent Societies. Eskild Peterson is co-chair of the Emerging Infections Task Force at the European Society of Clinical Microbiology and Infectious Diseases, otherwise known as ESCMID. Dr. Peterson is an infectious disease specialist from Denmark and is also the editor-in-chief of the International Journal of Infectious Diseases. Mary Louise McLaws is a professor of epidemiology at the University of New South Wales in Australia and an epidemiologist specialising in hospital infection and infectious disease control. Professor McLaws is a member of the WHO Health Emergencies Program. She has collaborated with Beijing in reviewing responses to the SARS outbreak and is also a member of the New South Wales COVID-19 Task Force. A warm welcome to you all. Now, Dr. Roz, if I could begin with you first. I want to look at the situation in America. As we know, it is currently the world's coronavirus epicenter. It has the world's most confirmed coronavirus cases, over 13 million, and more than 268,000 Americans have died. Can you firstly just bring us up to speed on America's coronavirus situation? And in your view, is this the worst it can get?
Well, very succinctly, I'll say that science has advanced faster than our wisdom has grown. So we've got lots of data flowing in. It's sometimes difficult to make sense of how to use it. And for that reason, the United States, which prides itself on individualism, and each of the 50 states have autonomy to make decisions about this virus, has gone in different ways. It's a good thing, generally speaking, because you experiment. You learn what works and what doesn't work in tax law or criminal justice or poverty management. But in the case of a virus, which is deadly, it makes it very difficult for public health officials, who often are overwhelmed anyway, to be able to communicate to local leaders who aren't epidemiologists, don't understand the subtleties of these decisions, and therefore they're forced to make decisions often based in fear, which is, as a surgeon, I'll speak to the fact that that's not how you want to make life and death choices, because you're fearful of one or the other. And I think that has left the country in a situation where there have been these super spreader events, which I think many in America did not appreciate were happening, but they've happened several times. In almost every one of our holidays, we had a super spreader experience that led to increasing cases. We had, for example, a children's holiday, really, over Halloween, which directly correlated with increasing rates as the weather got colder in northern parts of this country. And now we're in a situation that is worse than it was in March. And most of the folks who have studied these numbers suspect it will get at least twice as worse, as bad as it was in March by the time we're done this month in November in the United States, twice as many, almost every problem, including total cases, as there were in October. There's no reason to think December will be any better.
Okay, Dr. Neil Squires, can I bring you in here as well as Director of Global Health at Public Health England? How do you believe the UK has handled this, and what lessons have UK authorities learned from, say, authorities in the United States?
Well, I think the epidemic is different in every country, and I think we've all got huge amounts to learn from each other's responses. So I think the important thing to say is this isn't a competition between countries. Each country faces different challenges, and those challenges are due to different populations, different demographics, and the ability to control borders or the willingness to control borders. So in terms of the UK's response, we have seen a very devastating epidemic here. To some extent, that is due to the fact that the UK is part of an open society. It has open borders. It's continued to have travel and trade with its neighbours within Europe. And the levels of restrictions have gradually been increasing in order to try to contain the spread of the infection. But we've certainly seen with this second wave a much more rapid response to and curtailment of the epidemic. But we also have absolutely more information now than we did with the first wave. And we're also seeing sort of huge increases in the testing capacity. I mean, so the UK is now sort of testing over 500,000 people a day, and we've seen rapid advances in sort of, the potential access to both treatments and vaccines, with science having been mobilised. So although it has been a very difficult epidemic and it continues to be a major challenge for all countries, we can begin to see the light at the end of the tunnel. But as Dr. Tedros highlighted from the World Health Organization, we are going to have to live with COVID for a long time. And the way out of this does depend very heavily on strong collaboration and support between countries. And we absolutely must try to achieve equity between countries in access to the tools to control the pandemic. So the COVAX initiative to ensure access to the vaccine once it becomes available will be essential to ensure that all countries can benefit from the scientific advances.
Yes, and I do want to talk about the WHO COVAX initiative in a moment, but Dr. Jamila Mahmood, can I bring you into this discussion now? You're special advisor to the Prime Minister of Malaysia on public health. You're actively engaged in Malaysia's COVID-19 response. Now, Malaysia, as we know, is one of the advanced emerging economies, and throughout this pandemic, it's been interesting to watch how some of the world's most developed nations have actually failed in their response to this pandemic, whereas some of the more emerging economies, China, Malaysia, Indonesia, Southeast Asia in general, have actually been quite active and more successful in their approach. Can you tell me what sets these responses apart from, say, what we're seeing in the United States? How has Malaysia been able to cope better with this pandemic than wealthier nations?
Thank you very much. I think Malaysia has experienced some previous outbreaks of diseases. We've had SARS, we've had H1N1, we had a Nipah virus outbreak, MERS-CoV. So there has been some exposure in terms of how we're going to cope with some of these shocks. Now, none of us would have been prepared for the size and the magnitude and the extent of how COVID has spread. But we have invested quite heavily in our public health systems. And I would say that we have, really quite good health systems, which is ranked among the best in the world. And it also is something that is freely available. Health is free in Malaysia, literally, for $1 a patient. So that's one factor. So we have health systems that work. The second thing, I think, there was a very firm decision from the top leadership at the outbreak in March, when we had our numbers climbing, to quickly control our borders, really lock down the country, aggressively test as many people as possible, providing social protection measures to individuals and businesses so that people could then stay at home. And as a result, we were able to bring this down. Now, one of the other things as well is about cultural norms, right? It's been quite difficult, honestly, for Malaysians who are quite sociable people who love to shake hands and hug and so forth. So the culture shift has been quite a challenge, getting people to say don't shake hands, don't have family gatherings, which are very important. So this requires constant messaging. I think one of our biggest successes has really been in a very transparent and open communication. So we elected that the Director General of Health would be that constant figure appearing on television every day, speaking to millions of our citizens and giving them details of what was happening, numbers, where the spread was occurring, maps were open to public to look at, and so on and so forth. But having said that, I think that, we also learn from our neighbors. As an ASEAN region, we reached out to our neighbors. When Singapore had an outbreak with the migrant workers, we learned a lot from that. And now we're also experiencing, at the moment, a wave with migrant workers. So there has been, I think, a lot of humility to learn, to adapt how we adjust to the situation, but no sparing of testing, making sure that, we use data wisely, but constant communication with the public.
Professor Eskil Petersen, as co-chair of the Emerging Infections Task Force at ESCMID, you pretty much saw or tracked the evolvement of the coronavirus pandemic from China, then Europe, and then the rest of the world. You also are the editor-in-chief of the International Journal of Infectious Diseases. When you first saw the genesis of this virus many months ago now, it seems, back in January, even as early as December, did you ever think that it could explode into what we're seeing now, a global pandemic that's killed, infected millions, killed millions as well? Did you foresee this coming? Was the writing on the wall early on?
No, I must say that I didn't see it coming. The previous experience we have with pandemics is primarily influenza. We had the SARS outbreak of another coronavirus back in 2003, but but it was completely different, and it was rapidly controlled by public health measures like quarantine and isolation. But this coronavirus is completely different. When I was confronted with this outbreak, I thought, well, it will be over in 8 to 12 weeks, just as the influenza pandemics. We have had a lot of studies of the influenza pandemics, and they run a short course in 3 or 4 months, then they die out over the hot season and they come back. I think it has been a for all of us as this one is continuing, and I've been speculating why is that so, and I think that the prime reason is that for influenza, we all have some kind of residual immunity. We have been exposed to influenza since we were born. Some people have even got repeated immunization. So there is a background immunity against influenza in the population, which we are not normally thinking about. And that's, I think, is a prime reason why influenza epidemics or pandemics run a short course of 3 or 4 months. For this infection, there's no immunity, and that is why it's continuing, and maybe we can put a lid on so it will die down a little bit. But as soon as we sort of take the lid off, it will grow up again. And the studies on antibody levels in different countries have shown that we are not near what we call herd immunity. You will have to have 60% of your population immunized and having antibodies before you can speak about herd immunity, but we are not close to that. So this one, the chance we have now is to apply the vaccines, and that is going to save us over the next 6 months, I think.
And I definitely do want to look at the vaccine aspect in just a moment. But Professor Mary Louise McLaws, I'd like to ask you about the Australian experience, because at the moment, Australia seems to be on track to almost nearly eliminate the disease. They've enacted some of the most harshest and strictest coronavirus measures in the world, but it didn't start out that way. I remember at the outset, it seemed that Australians were ignoring the experience of China and the Europeans all those months ago, particularly in March. People were still going to football games, mass gatherings were still being held. How has the Australian response evolved, and how did authorities there learn from the outside world, I guess? Do you think they were too slow to implement some of the measures that were being seen in other parts of the world?
Yes, thank you for that question. In Australia, we are part of the WIPRO area, the Western Pacific region for WHO, but we are also, we believe we are firmly in Southeast Asia. And we like to learn from our Asian neighbours. So it was very heartening to hear from Dr. Jamila and how her country has learned very rapidly. So we initially were very slow to put up borders, and of course that goes against the IHR 2003 agreement, WHO agreement to not put up trade or travel of borders. But having learned from China, from their SARS experience. That's the one thing that worked very well. So we were a bit slow, and I can only assume there's this Western arrogance that these pandemics don't happen to the West. They only happen in Asia. So after many commentators, epidemiologists, infectious disease physicians were agitating that the response was a little slow. Mind you, compared to the rest of the world, our response was at lightning speed. The government put up restrictions for coming in. Now, what they did do, which was very sensible, was require people to be quarantined when they came in. And I know that sadly the UK and other countries don't do that. And that's problematic because as your travellers are coming in, they're adding to the prevalence of an already overstretched health service. We have, like Dr. Jamila mentioned, we also have a free health system paid through tax. So it's not a problem for our disadvantage for seeking health, which is very good, unlike, for example, the US, where people are often not seeking assistance with COVID because they may not be able to afford that health system. So we put up our borders very rapidly. We then put in quarantine. And the other thing that, like Dr. Jamila's country, our leaders got on the television every single morning and told their constituents for an hour exactly what was going on, case by case, exactly where some of the clusters were, even the early clusters. So it was flooding the Australian mindset with science because Australians, we are a multicultural community. About 42% of Australians or their parents come from overseas. But as a general tribal approach, we are very driven by science and logic. So the federal government told the people that they needed to have a stay-at-home stint, and Australians accepted that. And you've probably heard, of course, that there was a second wave that was seeded in Victoria by a quarantine hotel non-compliance, and that went into the community with a very high second wave of about 25,000 cases. And for Australia, that was enormous. And their authorities told their constituents, you have to stay at home. And for 114 days, they did. Now, I believe it's because we are a highly peaceful and compliant community, but we also take on board what Dr. Tedros said, and also what an earlier speaker in one of the early sessions, Mr. Ibrahim Khalil, mentioned, and that was the we. So I think that, like in Malaysia, Australians think about the we instead of the me, and so when they are told that this is what they have to do in Victoria for 114 days to be locked down, they did it in a very compliant manner.
Now, Dr. Oz, turning it back to the United States, and I'm mindful not to treat you as the ambassador of the United States, but you have seen the pandemic evolve from the early days in the US. You live there, obviously, but I'm wondering, what is it about the American psyche, or at least parts of the population there, where despite seeing images of thousands of people dying in, say, China and Italy and other parts of the world, that the seriousness of this pandemic really didn't manage to resonate with some aspects of the population, including the man at the top, Donald Trump? What is it about that mentality that really, in your view, prevented people from acting early and acting hard?
Well, I think it was one big psychology test. The country is a bit isolated geographically, so many people in the United States have not traveled around the world. So the images from other countries seemed a bit foreign. But even within our country, we were having crises. For example, here in New York City, in this part of the country where the pandemic hit hardest back in March and April. So the policy approach was to shut the entire country down, to pull the emergency brake because we didn't know what we were dealing with. And if you lived in most of the country, there was nobody near you who'd ever had the virus, no one that you knew had been made sick by it, certainly. And that continued for months. So meanwhile, while you lost your job and income disparities are significant all over the world, as well as in this country. So you've lost your job, you've been isolated, deaths of despair beginning to increase, drug use, suicide rates increasing, and yet nobody near you has COVID-19. And so finally, New York, New Jersey, this area recovers. The outbreaks in the coastal cities that were exposed from the virus from either Europe or from China begin to recover. But throughout the southern part of America, there had not been really much of an impact from COVID-19. Hospitals were shut down, but there were no patients in them because there was no COVID-19 in their community. So what would you do? Well, the average American said this obviously wasn't that big a deal, and they began to bend the rules. And they were bent with super spreader events, which we now know are much more problematic than the one-on-one spread that was initially thought to be the biggest issue. And that led to major outbreaks over the summer in the southern states where they were using air conditioning, going indoors again. And again, indoor spread is 20 times higher than outdoor spread. So that led to a dramatic increase in cases in Florida, Texas, California, Arizona, states that had been exposed later, but had no real mental framework with which to deal with it, because the first time they were told to shut down, nothing happened. And as that passed, the northern parts of the country had been free of viruses. Here in New York, for example, there were very few cases throughout most of the summer and into the fall. Despite that, I should point out, they shut the schools down in these parts of the country, which did not happen in most of the world. And the irregularities, the irrationality of policy decisions began to wear down Americans, who began to disbelieve that the public health advice they were hearing was based on science, even though it was always said to be based on science. But the hypocrisy around some of the decisions began to strike. And I'll speak specifically to schools, since it's a hot topic now in this country. In New York City, schools were shut in September when there were no cases. They were opened and then shut again with an arbitrary number that was really not based on any science. Now with cases twice as high as they were when they were shut, the schools in New York are opening again. And all of a sudden, a debate about whether to open schools, which was primarily political at times, has now moved more into the public health arena, as it should be. And there's more uniform belief that we should keep the elementary schools for young children open, because that doesn't seem to be the main way the virus spreads. Data which was readily available on modeling forms in March and in real experiences in May, June, and July, but was ignored. And so if you're the average American, after a while you say, well, I'll trust my governor. And the governor is looking at data which doesn't seem to make a lot of sense. And they make decisions that are literally opposites of each other. And so the average American doesn't know what to believe.
Now, Dr. Squires, looking at the UK experience, some people had criticised Boris Johnson's government for being too slow to act initially as well. People were travelling from Milan into London and were tweeting that they were surprised by the fact that there didn't seem to be any border checks, even though a couple of hours away people were dying in their tens of thousands. But that quickly evolved. But to what extent do you believe is the UK's national health system, the NHS, was responsible for really clamping down on the pandemic in the UK? I guess my broader question is this pandemic, did it really highlight the importance of a national healthcare service versus one that's largely privatized, say, in the United States?
Well, the National Health Service is a real treasure of the UK, and it gets huge amounts of support. And a lot of the public messaging around the epidemic, the pandemic initially, was save lives, protect the NHS. And clearly that was an important message, because people do benefit and have huge faith in sort of, universal health coverage provided by the National Health Service. So these free access to healthcare when you need it is vitally important. But clearly capacity is limited, and it could be seen once the demands on particularly intensive care services were increasing, that the system was vulnerable, and it is an important part of the messaging. But in terms, I mean, an important point to make about the early stages of the pandemic is that we have been learning constantly. And so the messages have had to evolve to respond to the changing understanding of the epidemiology of the disease. And also, we have to understand the International Health Regulations, IHR 2005, has previously been mentioned. But we have got an international system that's been specifically designed to protect travel and trade because of the recognition of the harm that happens to the global economy if you clamp down too rapidly in response to infection threats. So, to some extent, the way different countries have responded have been to protect the economy when it wasn't clear what the health impact would be. And it's very important to look at the differential health impact in different countries because the same response and one size does not fit all for all countries. And we're certainly seeing in some countries with very young populations, a number of countries in Africa which have an average population age of 25, for example, for them to shut down completely, to exclude children from school, may not be a balanced response to the level of risk that they face. Whereas in the UK, where we have an aging population, we have multiple comorbidities, then protecting the health becomes critically important because the risks in terms of mortality are much higher. So again, I just want to discourage this idea of comparing countries with this being some sort of competition between them for the success of our response. All countries have to respond in the way they see most appropriate to protect both the health of their population, but also the economy, which will ultimately impact on the health of future generations. And it is a titration act that politicians have to balance public health interests against economic interests. And so there isn't really a simple solution or a good response or a bad response in that respect. When you don't have adequate information. I think if we all had the information that we have now at the beginning, then we would have seen a very different global response. And we have learnt, and we need to continue learning. And this process of sharing information and understanding between countries is vitally important for that process.
Dr. Mahmood, I'd like you to reflect on your time as Under-Secretary General of the International Federation of the Red Cross and Red Crescent Societies, which, as we know, is most active in the emerging world, in poorer countries. Do you believe that in this hyper-globalized world that we're living in, which often refers to trade, but in this time we're talking about this in the context of the pandemic, do you believe globalization has been a help or a hindrance in terms of supporting these poorer nations who don't have the facilities that, say, the US, the UK, and even Malaysia have?
Yeah, I think, if it's one thing that the COVID pandemic has highlighted to us is that we are so interconnected. On one hand, globalization is the driver of the spread of the virus in many cases, but it's also a huge opportunity for collaboration and coordination. So I think, we've heard very eloquently from the last few speakers how it's not about a comparing game, it's about a learning game, it's about an adaptation game, and about an acceptance that each context is going to be very different. Now, working in the International Federation of Red Cross in the past, it is very much a grassroots organization in 192 countries. And the pandemic itself must be rooted, or rather the response to the pandemic must be rooted into how communities actually behave. Because we know that no matter how strong your health systems are, no matter what medication you have, the best treatment for a pandemic is good public health measures. And that is really calling for behaviors that are very are protective of communities. So I think this is where, governments have a very specific role to play in terms of policy driving, health interventions that will protect health systems, particularly driving actions that will look at how economic impact might be mitigated. But on the other hand, really also empowering communities and allowing these communities to organize themselves. And we've seen this in, how it's worked in many countries. Let me give you a classic example of Vietnam. I mean, it's been hailed as one of the best results that we've seen in the pandemic management. It's because people took charge and protected their own communities and their neighborhoods, making sure who came in and who came out. They screened them for symptoms and so on and so forth. Simple measures, but really protected communities. And I think globalization is critical now in a positive sense in how we've collaborated on the vaccines and so forth, how we're learning from each other in events like this and also other platforms. But let's not forget the localization of response is also going to be very, very critical in managing the pandemic. And this is where organizations like the Red Cross and Red Crescent play an important role.
Professor Peterson, as you've been watching this pandemic unfold, have you been pleased with the level of international cooperation that has happened over the last year in terms of helping to tackle this pandemic? We've seen examples of countries like Turkey, for example, using its strong manufacturing sector to distribute PPE gear to countries like the UK and elsewhere. But we've also seen examples, say, from the United States, where they've actively looked to intercept shipments of US deliveries of PPE to other countries around the world as well. On balance, are you happy with the level of global cooperation there has been in terms of tackling this pandemic?
No, absolutely not. What you can see and what actually did happen was that each country developed their own model. And that's also what we've heard the other four speakers explaining, that each country actually had the responsibility. And of course, also the WHO, who is supposed to guide us, they had to look to do. And as I said in the beginning, I thought this would be like a flu pandemic, but it was not. So it's clear that for some countries, like I could mention Korea and Taiwan, who did a very successful control of the first wave, that was because they closed borders. And that was not in line with the IHR regulations, but it worked because the travel, the amount of travel we are seeing these days are much more, much higher than it was in the SARS outbreak in 2003. So each country was sort of left on its own, finding its own model. Of course, we looked at each other, tried to learn, and I'm not sure we have actually learned, because if we look at the US, they have followed one path, the UK have followed another path. We in the Scandinavian countries are following a third path, and Malaysia and Australia are very much like the Scandinavian countries, with a huge public sector with almost no private healthcare. So I think that the international collaboration has lacked, but I'm not surprised. And what else could we have done? I mean, it's my government who have the responsibility. It's not the WHO who has a responsibility for me being a citizen of a specific country. It is the government of a specific country who has a responsibility for the citizen. And I think that what we can do is that we can say, okay, so that's what happened. What really is a challenge now is to get the vaccine rolled out in a global scale, because we cannot control this unless we also make sure that disadvantaged countries get access to the vaccine. I think that's the importance now, and that will show whether we can build international collaboration around vaccine distribution.
Okay, Professor McLaws, I'd like to just reflect on a point that Professor Peterson made, that it is the responsibility of individual governments to enact a response to the pandemic, not global organisations such as the WHO. And we know the World Health Organization has both been praised and criticised for their response since the pandemic first evolved in December, January. As someone who still works actively with the WHO Health Emergencies Program, how would you rate the WHO in terms of how it's handled its response during this crisis?
That's a very difficult question because, of course, I'm a little biased working within WHO as a voluntary expert. There are many things that each organization can learn and improve. And we've all talked about the international health regulations of 2005. So that health regulation is a legal document that requires all member countries of WHO to respond in a particular way that they've all agreed upon. And one of them was not to put up borders, not to stop trade and travel. Now, that was developed in 2005 after SARS, which had a much lower transmissibility. And of course, it was previous to the pandemic influenza, which of course has a less transmissibility than this infection. So it's now time for WHO to get their member countries back to the table to start talking about that regulation that is now 15 years old, to identify how best they can be refreshed according to the next pandemic, which won't necessarily have a transmissibility of flu. It may be as bad as COVID-19 or even worse. So that's one improvement that WHO could do. Also, there's an idea of lack of transparency, but what the average citizen, global citizen, doesn't appreciate is that WHO and the top leadership work for the member countries on behalf of the member countries. They don't make decisions themselves. They are advised about decisions. For example, calling something a public health emergency of international concern isn't Dr. Tedros's decision alone. It's the member countries. And, you know, there was a criticism that took too long. So maybe now is the time to either have some sort of grading system to give the community an idea, and I'm talking about the global community, an idea of how serious the member countries are taking a new novel disease or an old disease that is threatening the global health, instead of it being, which it is, in confidence while they're having this meeting. None of them talk about it publicly. Each one of those experts from the member countries, of course, tell their member countries what's going on, but the rest of the global community don't know. So maybe now's the time to look at that and make a change. That maybe that could help bring on board the rest of the community. But there was a lot of criticism about WHO from one particular world leader. And then that caused an onflow of, I think, a lack of trust, which hadn't been there before. I mean, this was the first time a country was shamed by another member country for a pandemic. We've had MERS, we've had SARS, we've had bird flu, and yet no country had been shamed like one of the member countries was trying to shame China. And that doesn't help. And then there's this vision that WHO is somehow biased towards China. Rather, it is a bias towards an even-handedness of getting the job done, of learning and waiting for the appropriate time to go in and do some more searching, soul searching.
And that member state which has heavily criticised the WHO is, of course, the United States. The Trump administration has officially begun the process to withdraw the US from the World Health Organization. Presumably, when Joe Biden becomes president in January, he'll reinstate America's membership into the WHO. But Dr. Roz, it is a couple of months away until Joe Biden does take the oath of office in the US. But do you believe that his approach, his drastically different approach, which he has promised, will change the course of the pandemic in your country?
I'm not sure if it will change the course of the pandemic because the actions that are taken at the federal level take quite a while to reach down into the trenches where the battle is being fought. I do share your optimism that the United States will be back in the World Health Organization. Whatever flaws may exist within large international groups, there's still a benefit to having a common ground to speak. And I know members of the Biden administration are going to be supportive of the U.S. playing a more active role in that regard. But when it comes to managing the pandemic, I mean, that the big and heavy lifting was already done during the Trump administration when the vaccines were developed. And around the world, I know China and Russia, the UK, and here in the United States, they're promising vaccines, at least 24 more that are coming down to us pretty quickly. And we have proof now that we can save lives providing a vaccine that works at over 90% efficacy. So it's just a matter of getting it out the door. This country will approve the 2 mRNA vaccines this month. Today, there's a meeting in Washington to discuss how the vaccines will be distributed, but we know the first group of people will be healthcare professionals. That'll start happening this month. And over the next 3 to 4 months, I believe that 100 million Americans will get vaccinated, and eventually 2/3 of the population. 1/3 of the population here will probably reject the vaccine, at least initially, until they see their friends and families successfully receive the injections. That may be a number that's reflected in other parts of the world. But with a 95% efficacy rate, even 2/3 of the population can give us herd immunity if you also add in people who've been exposed to the virus directly. And the newer data we have on T cell length of life and memory makes me confident that we'll be able to get at least a year, hopefully more, out of these vaccines. So it'll effectively suffocate the virus here in America. You raised the point earlier, and panelists have highlighted, Dr. Tedros as well, that we have to be able to stamp out the virus everywhere or it will just keep coming back to get us. So that's the big challenge now, to make affordable vaccines for the rest of the planet. But in this country, the political issues will die off as the vaccine dies.
Okay, I think now is a great time to talk further about a potential vaccine. Dr. Squires, we know we have 3 vaccine candidates that have produced promising results. The candidate by Pfizer, Moderna, and AstraZeneca, Oxford University. Firstly, briefly, and I want to follow up after this, when do you believe we'll actually see the rollout of a safe and effective vaccine?
Well, this obviously depends on completion of the final sort of safety checks and then the speed of production, but also the mechanisms that are put in place to ensure equitable access. So I know a number of countries have pre-ordered large numbers of vaccines in order to protect their own vulnerable populations. But there's also been significant investment in something that we've called COVAX, which is about creating this global financing facility to enable countries without that level of resource to also benefit from vaccine development. And that's critically important. I mean, I think there has been a huge amount of sharing of expertise, sharing of scientific knowledge, and we need to build on that sort of collaboration and cooperation, which has led to the production of vaccines so rapidly. I mean, it's an incredible scientific achievement to have produced effective vaccines in such a short time frame. And we need to make sure that that then translates into a rapid, equitable access to those vaccines. And so the funding of it is critically important. And I mean, organizations like the World Health Organization are critically important to that. And their facilitation of sort of creating those financing mechanisms and Dr. Tedros's own advocacy for equitable access and its importance for the world to see that the global community will increasingly collaborate to tackle these threats together is critically important. And I highlight this in particular because moving forward, if we do want to have effective preparedness against future pandemics, then we need trust in both the global institutions, but also in each other in terms of country trust. Because unless countries trust one another to share information in a timely way, then we won't ever develop the rapid pandemic warning system that we need to be prepared for the next threat. So again, the message that emerges from all of this is the need to strengthen our ties to avoid negative criticism of other countries and to work collaboratively in future, so that we can achieve something together. We're only as strong as the weakest country, and therefore collaborating to achieve the maximum impact is absolutely essential.
Dr. Mahmood, I'd like to ask you about one of the points that Dr. Squires raised, and that's the fact that wealthier countries such as the US, the UK, Germany, Australia, and others have really been pre-ordering millions of doses of vaccine in anticipation of a successful candidate, which is really within their right. They are looking to protect their own populations. They have the means to do so. But where does it leave poorer countries who don't have the means to spend billions of dollars pre-ordering these vaccines? Are we inevitably going to end up with a world of have and have-nots in terms of a successful coronavirus vaccine?
Well, I certainly hope not. And I think this is the reason why the COVAX facility is so important. It is allowing equity and access to the vaccines that are produced. So even a country like Malaysia, we're kind of caught in a little middle income trap because we're not developed, we're not underdeveloped, but still we've opted to actually participate in COVAX because it's beyond just equity. It's also global solidarity because, we are only as strong as our weakest link. We are not safe till everyone is safe. So taking that attitude, it is a heavy investment for a little country like ours. But I think, even if we look at it at a global picture, it's massive. But I would also think that in Asia, at least in the ASEAN region, Southeast Asian nations are fairly close. There are mechanisms within ASEAN, and a lot of dialogues are happening now. And I really wish that the regional bodies could also play a very active role in really pushing for that solidarity to ensure that our neighbors also will benefit from the vaccines when they're available. The big issue for me is also the misinformation that is arising because of vaccine production. As mentioned before, we've never seen vaccines produced at this speed and with so much success in the phase 3 trial. So I think that's another hurdle we're going to have to cross at some point, because there will be lots of questions in terms of whether the vaccine is safe or not. And I think these are some of the things we are already starting to prepare for, because that will be another communication exercise that needs to be invested in.
Now, Professor Peterson, can I ask you about your thoughts on the potential vaccine candidates? Do you believe we are close, as some people would suggest, to seeing a safe and effective vaccine rolled out perhaps as early as later this month in the new year?
Yes, I actually think so. Looking at the clinical trials, they have been very large, about 30,000 in each of the three leading candidates in the UK and the US. And we don't know very much about the Russian or the Chinese vaccine, but for the three leading candidates in the US, I definitely think so. We need it. We need to open schools, community. We need to open travel again. So the vaccine is really where we can make a difference. And when we look at the reported side effects, they are very mild. You get some local pain, redness, maybe a short fever in 24 hours. And this is what we know from other vaccines. So there's nothing here indicating that these vaccines are in any way not solidly investigated. I absolutely agree that the speed has been impressive, but also the number of people who have been involved in the clinical trials over the last 3 months has been impressive. And that means that we have a very solid guarantee that there's no major very common side effects on these vaccines. Of course, we may see something in 1 in 100,000 vaccinated or 1 in a million, but there's no way we can foresee that. So my advice to everybody is looks like very good vaccines, and go and get it as soon as you can.
Now, Professor McLaws, can I ask you to elaborate on the WHO's COVAX initiative? So this is the initiative, as we've heard from the previous speakers, that really aims to distribute any successful vaccines equitably around the world. We heard recently at the G20 summit in Saudi Arabia that world leaders are committed to this initiative. They didn't really, specify a dollar amount to which they're prepared to support COVAX, but at the very least, on paper, they are for this idea of the fair distribution of a vaccine. How will it work, and what will it take for the initiative to be successful?
So first of all, I'd like to go back to what Professor Peterson was mentioning about the safety, and just remind your viewers that each one of the pharmaceutical companies signed a letter and sent it to the International Pharmaceutical Federation, all agreeing that they would not cut any safety corners. So we have that assurance that they are all there for safety. WHO had a recent open meeting for all of the, we've got about 8 themes. There's the epidemiologist, the infection control, therapeutics, vaccines, etc. And this was an open meeting talking about the importance of the trials continuing and not breaking protocol. And there was a unanimous approval that this should not have stopped early, that even with the emergency use authorization that, for example, America and the UK and other countries are looking towards, that the trials should continue as well, because we'll learn a lot about the trials. But getting to your question about the distribution. So the COVAX facility requires each country to receive 3% of their population's doses initially. And of course, COVAX facility doesn't prescribe who in each country should get this. It's up to the country, but initially that 3% is seen for frontline healthcare workers. I believe that each country will probably need a bit more than 3%, because while frontline clinicians are important staff include environmental cleaners, those that run the hospital. Without everybody being protected, it's going to be very difficult. So they get 3%. Then there's an additional 17% rollout, and that's for high-risk groups. And I think WHO is imagining that that will be for the elderly. Now, that will work well if the vaccine has an adjuvant that assists the elderly immune system to kickstart it. If it doesn't, another approach might be that each country looks at its epidemiology and identifies which group is driving this disease, acquiring it and driving it. And it seems as if worldwide, it's that 20 to 39-year-old group who are doing exactly what 20 and 39-year-olds should do, and that is socialize, go to work. So therefore, they are at risk of acquiring it and spreading it. And in my end of the world, of course, about 44% of cases are between that age. So if you vaccinated them, you would ring fence and protect the elderly if some of the vaccines aren't highly effective in the elderly, but let's hope they are. Of course, the other group for this 17% is for those with a comorbidity. So anybody who's elderly usually has a comorbidity, but then so do the young have comorbidities. So that may take a full 17% of those doses that you'll get. And then eventually another 20% will be rolled out. Now, that's for potentially vulnerable. And Dr. Tedros keeps talking and reminding us that this disease is, it rips the Band-Aid off inequity. You know, every society hides its inequality, and, you know, pandemics open this up. And it's the disadvantage that acquire this disease and sadly spread it because they live in high densely populated living conditions. They work hand to mouth and many jobs all at once. So one would hope that we would include the disadvantage, and each country will have to work out how to identify who they're disadvantaged. In some countries, everyone will be disadvantaged. So that's the 50% idea of the rollout. And then, of course, there are other countries that, like my country, are having a bet both ways and are also buying or investing in some additional doses.
Now, Dr. Rolls, on your show, you regularly debunk a lot of the medical myths that are out there. And I guess one of the pitfalls of a hyper-globalized world is that conspiracy theories, fallacies just can catch on like wildfire in an instant, really. But can we look at the issue of vaccine hesitancy? I don't want to so much look at the so-called anti-vax movement, because there'll always be people who are against vaccines based on false information or assumptions. But is it fair for people to at least be a bit hesitant about a potential coronavirus vaccine, given the record speed at which these vaccine candidates have been developed? For example, would you be taking the first vaccine that rolls off the production lines if and when the FDA does approve it?
I would happily take the first vaccine off the production lines, but I do respect the hesitancy of 1/3 of Americans, and I suspect many around the globe, to get a vaccine. To your point, it does seem rushed. Operation Warp Speed, which was the name of the program in this country to accelerate vaccine development, makes people think that corners were cut. And in fact, there was red tape that was being cut to accelerate the approval process and distribution of vaccines once they were found to be safe. The top 8 vaccine manufacturing companies all signed a petition saying they would not submit even for approval in this country until they were 100% sure of their data. They weren't going to be bullied by politics or other pressure from non-scientific arenas. But I got to say, the issue with vaccination fear is not a new one. When the smallpox vaccines were developed initially by administering cowpox 200 years ago, there were wonderful stories of parents hiding their children in England in the chimneys so they would not get vaccinated because they were worried. And moms arguably say, who loves my child more than me? No one. Can you prove that you care about my child as much as I do? Why would I take a chance by giving them a vaccine? That's one of the reasons I've been telling the American public, and my show, as you know, is in 100 countries, so I try to tell people all over the globe that it is important not to pressure people when they're not ready to hear the message. So instead, I tell people, listen, let your friends and family get vaccinated first. We don't have enough anyway, so you don't have to go first. We'd prefer you not. Let someone else go first. When they do well and you're comfortable that they've had outcomes that are reasonable for you, then you can get your vaccine if you desire it. Thankfully, the success of these vaccines, the mRNA vaccines in this country in particular, are high enough. And it's reflected from what I can tell with the AstraZeneca vaccine eventually when the data's reassessed with a larger trial, and the Russians are claiming similar numbers as well, that these vaccines addressing the spike proteins do seem to work. So even if we don't vaccinate everybody, we should still have enough people protected to put a dent in the ability of the virus to spread. But I would say energetically, when you pull people too hard or you insult them by saying they're foolish for believing lies, they don't react well to that. In fact, they begin to live in a different world. The better tactic, and I would encourage this of the World Health Organization, is make a poster of the top 5 reasons not to get the COVID-19 vaccine, and then debunk them. Because people are having those conversations on social media and in back alleys anyway. Just confront the arguments head on. Here's reason number 1. mRNA vaccines have never been made before. That's true. They haven't. However, there's lots of data and then the rest of the story can come out because you've asked a question that they're wanting to ask, but are afraid to ask you as a doctor because they think you're going to feel less about them because they were even willing to ask the question.
Dr. Squires, in the UK, there traditionally hasn't been this so-called anti-vaxxer movement, but through, I guess, the magic of social media, we are seeing some figures really gain a lot of support quite quickly against, firstly, the so-called myth of the pandemic and a potential vaccine. Do you envision there to be significant resistance against a successful vaccine when it does get approved in the UK?
I don't think there'll be significant resistance, but there will always be people who are hesitant. I mean, I think we do need to, as has been said, put out the information to give people the confidence that they need to make the right decision. So I think one of the potential benefits globally that has come from the level of debate that's occurred around COVID is an increase in health literacy more generally. And I think we do need to capitalize on that. I mean, you've never heard so many messages going out about the importance of hand washing and hygiene and sort of sneezing hygiene. And that will have tremendous benefit, particularly in developing countries and others where these messages previously haven't been heard and communicated. So I think one of the challenges is to how do we build upon this effective communication of government, politicians, and everybody to convey health messages and extend beyond COVID and the immediate threats to broader messages about people protecting and improving their own health, addressing some of the risk factors for COVID, but for many other diseases. So tackling non-communicable diseases which kill far more people than COVID is killing, cardiovascular disease, diabetes, the problems linked to obesity. All of these other health problems are things that will continue to kill large numbers of people for years to come, where we do need to ensure there are effective health messages delivered to populations. So when we're thinking about how do we communicate effectively with populations to help them make healthy choices, we need to think about it in a holistic way and move beyond just thinking about COVID, which is today's problem, to thinking about, well, how do we enable and empower, particularly poorer, marginalized, more vulnerable sections of society to have the information they need to make healthy choices. So I think we need to take a much more sophisticated and a broader perspective of this whole communication challenge.
Dr. Mahmood, I want to ask you a similar question because generally in Southeast Asia there hasn't been this resistance towards immunizations and vaccines, but in countries like Pakistan, for example, there still has been this, I guess, conspiracy theory against the polio vaccine. Do you expect there to be challenges in terms of vaccine hesitancy? And what can be done in order to better inform the public in Southeast Asia, North Asia, and in South Asia about the virtues of a successful coronavirus vaccine?
Yeah, I think I completely agree with Dr. Oz that, no matter what you do, there will be the skeptics, there will be people who fear, but I really don't think they are the majority. Now, in some communities, obviously, there have been a lot of suspicion around vaccination writ large. It's not just about being anti-vaxxers, but also being really afraid of anything that is with a needle injected into someone, not knowing what the outcome will be. So a lot of, I think, advocacy, communication, simple messaging. And I think people are also very tired of the pandemic. Everybody wants to go back to routines. And I think this is going to be a major driver in people wanting to take the vaccine. If I can speak from a Malaysian perspective, our people are just as active on social media. So you get 150 theories coming out even before a vaccine has gone to phase 3. So, all these conspiracy theories will go on, but we need to tackle them one by one and not just brush them off. One factor, I think, which is quite unique, particularly I speak as a Malaysian, but also as a Muslim, is that in many countries around the world, the question of whether the vaccine is halal or whether this is permitted in religion is going to be an important one, particularly in countries also like Pakistan and Bangladesh, which are highly populous. One of the things we have been doing is, Malaysia is quite advanced in the halal industry, in really bringing the religious leaders and the halal industry to look at, how might we want to certify, if possible, the halalness of a vaccine. Now, having said that, Islam allows you to take non-halal things in an emergency. And even for a Hajj or pilgrimage, one of the vaccines that is given, the meningococcal, is definitely porcine derived. So it's not an issue. So I think we've got to get that messaging right? That this is, even if we don't manage to get, to the halal stage, that it is permissible in within your culture, within your faith. And I think this is something that it sounds trivial, but actually it's really, really important in many communities. So I think we're trying to look at it from a very comprehensive range of issues that might arise, and also finding, the right messengers as well to deliver the message. It has to be someone trusted by the community, someone trusted by, different age groups, whether different faiths and so on and so forth. So I think breaking it down into, what might be easier bites to take, but really keeping everything very simple, but also very engaging and being very honest as well. I think when we don't know everything, we have to say, well, we don't know yet. Let's wait for that. And I had a call with AstraZeneca and I said, well, where are the peer reviews? It's I don't know if anyone feels the same way as I do, that we're learning more about the vaccines from media than from peer review papers. So, and it's quite interesting. We've never had this before, but I'm happy to know that AstraZeneca will produce their peer review paper on Friday. So there's a lot to look forward to in looking at the science of it.
Okay, Professor Peterson, on the 8th of May in 1980, as you're well aware, the World Health Assembly officially declared that smallpox had been eradicated, but it did take 184 years since the first vaccine was developed in order to achieve this. So, firstly, do you believe that any successful coronavirus vaccine will be the silver bullet to this pandemic? And secondly, do you believe that coronavirus is something that we will have to live with for the foreseeable future?
The silver bullet, which will end the current within the next year or so once we have rolled it out. Just to come back short to vaccine hesitancy, I'm giving talks on vaccine hesitancy. And there's in particular a French study which is worth mentioning, where they showed that if you trusted your family doctor and the family doctor talked to you about the vaccine, then actually the family doctor was more trusted than the internet. And I think that's very comforting, that we are all role models. And if we as role models speak up and discuss it with these people and take it in a positive way, then we definitely can break through. To come back to the to the future, it's always a privilege to be able to speculate about the future. And I don't know if we have seen the last of the coronaviruses. We have 4 viruses which are circulating, and they give mild flu, upper respiratory tract infections. But this is a zoonotic virus, and it moved into humans because close contact between wildlife and humans. So that is where maybe 80% of the outbreaks over the past 60 years, that's zoonotic diseases. And that's why we can foresee that outbreak. We have seen in Denmark that we have mutated coronavirus in humans, and that may happen again. It may happen with other viruses. So I think that coming back to what Dr. says about the role of the WHO, and I'm a of the WHO, is that we have to strengthen the public health, and we have to strengthen the One Health approach, because these infections, they come from animals, and we need to, and also the 2009 pandemic of influenza came from pigs and moved into humans. So the large scale, shall I say, raising of animals with thousands together in close contact with humans are going to give us more pandemics in the future, whether coronaviruses or not. I think that one of the comforting conclusions from this one is that we can actually manufacture a vaccine months, and probably we can do it even quicker if the backbone of the vaccine is now approved, so we can just put in some other antigen. This is actually what we do the seasonal influenzas. So we are not seeing the last of the coronaviruses, but the response next time will be much quicker.
Professor McLaws, Dr. Mahmood mentioned earlier that countries like Malaysia, Singapore and others in Asia had really learned from their experience in dealing with the SARS outbreak. You yourself helped countries like China evolve their response to that outbreak. Are you hopeful that other countries around the world, when this pandemic is over, will have taken the lessons learned on board to apply in the future? Hopefully, we won't see a pandemic on this scale in our lifetime again. But are you worried that perhaps countries will forget about the horrors of this pandemic sooner rather than later when this is all over?
Yes, it's an important issue that we need to discuss. The speakers tonight have all talked about pandemic fatigue, and it's real, even if they're not overly fatigued by fairly strict lockdowns, except for the Northern Hemisphere is now going into that, and they'll be physically fatigued. They're mentally fatigued from bad news. So we have to acknowledge that, appreciate it, and ensure that we don't allow that to stop us from planning for the next pandemic, because leaders often want to tell their constituents good news. They want to move on and get the economy rolling. However, there's been tens of millions of global citizens that have had their lives shattered by this, and 1 million and more that have lost a family member. So leaders have to acknowledge and respect this and say to their communities, we're not going to squander this opportunity to learn from how they themselves responded, how their citizens responded, how we've responded to our neighboring countries, because Dr. Jamila talks about, thinking about our neighbors as well, and that's very important, and so did Professor Peterson. And we have to look after our neighboring countries and then our region so that we can then become good global citizens for the next time, because there was a global preparedness monitoring board report written in September 2019, and it was called, if I remember, The World at Risk. And it warned everybody that there was a global pandemic on the horizon, and we all ignored it. And of course, a few months later, that's what happened. So September this year, they wrote a report called World in Disorder. And what they have reminded us is not to lose this opportunity and not to do the panic and neglect. We panic when an outbreak occurs, and then when it's over, we neglect it because we just want to get on with life. So we need to use that so that we can learn from the catastrophe to convince those that are pandemically fatigued, what are we going to do next? And I think one of the most important issues is outbreak managers see things differently. We ring fence, we lock down, we put masks on people, and it'll all be okay. The economists see that as disastrous. So the two professions need to come together to work out how in the future they can look after the safety of the health and the safety of the economy together while squashing a new pandemic, so that we can then survive and learn. We also need to come together as a global group, either regionally or globally, and share what did we do right, what do we wish we had have done, and Dr. Jamila talked about learning from her neighboring countries about what they did right and what they did wrong, and from Vietnam. And I think that we in the Western Pacific region can learn from our neighbors who've had not just experience with COVID, with MERS, with SARS, with bird flu, and come together and become a regional force. And of course, Professor Peterson and Professor Squires come together in the northern region with their countries and learn how best they can do this with a very open-bordered Europe. How can they do this together so that we can learn, so we never have to go through this again, because really we need to leave this world into a safer place for the generations to come.
Dr. Roz, can I ask you a similar question? We know the United States is the wealthiest country in the world. It's also a diverse country in terms of its people and views. You had Americans like Bill Gates really warn of a pending pandemic just a couple of years ago, but then you've got people like Donald Trump, who said that this pandemic would be over and done with by April, by Easter, as he said at the time. Do you believe that America has learned its lesson after 13 million confirmed cases, 268,000 deaths? Do you believe that America will learn from this experience and not take a pandemic so lightly in future?
There's no question that future responses by the United States will be more in line with what we saw in Asia. But remember, it's not just the United States. There were similar miscalculations in parts of the world that had not been hit by prior infections, viral infections in the past decade, Europe being a good example. And not every part of this country has been hit with equal harshness, and nor will people be equally influenced. It's just such a diverse place. But I think that when a future virus hits these shores, you'll have a population much more adept at rapidly addressing issues like social distancing and wearing masks, a lot more comfort around taking steps that seem to violate the Constitution of this country. And that's where the tug of war is going to happen. Just this week, there was a ruling by the Supreme Court of the United States against the governor of New York State, who had shut down the churches in the state or restricted them. Yet the bars were open. And so the Supreme Court justice has said, well, that's a very convenient decision about what's a public health issue. If going to a bar is considered a public health factor and needs to therefore remain feasible, but you can't go to church, that seems subjective. And so that's where the tricky decisions will rise as America tries to deal with future infections. But the baseline public health problems are going to have to be addressed by investing in public health solutions, which has not been done in this country. In fact, quite the opposite. The defunding has taken place both in the Trump administration, but in the Obama administration as well. It has not been an area of huge focus, which is one of the reasons that the initial response was so slow and misdirected. Easy to criticize now, sitting here 10 months later, but we just don't want to repeat that same error again in the future.
Okay, Dr. Squires, what about your thoughts about the future? We know the UK is in a unique position where it is made up of devolved nations, each with their own government, autonomous from the government in London. But overall, when this is over in the UK, do you believe authorities will have learned their lesson and will apply some of the lessons learned over the last 10 months, hopefully to deal with a pandemic that won't happen in our lifetime?
Well, there's a constant process of lesson learning as sort of new lessons emerge, and yes, definitely, we've already learnt many lessons as the pandemic has evolved, and we're actively sharing information and learning from other countries every day with regular communications, meetings between countries to share, and that's something that we absolutely need to continue. But on the US, we also need to remember the huge investments that the US has made through the Centers for Disease Control in building up global epidemiological capacity. So let's not let the response to one epidemic colour our view of a whole history of investing in global pandemic preparedness. Yes, I mean, there may have been faults with the coronavirus, but we've heard from many experts that nobody anticipated the pandemic would be like this. Many countries around the world were anticipating something much more like an influenza pandemic. And so, although there was a loss of preparedness, we weren't prepared for coronavirus. And so it's just helped us to recognize that the range of our preparedness needs to be increased. And it may well be the next global threat is not even infectious disease. I mean, it could be climate, it could be biological or chemical. So we need to actually have an all-hazard preparedness that means that we collectively think about the various disaster risks that exist. So alongside the international health regulations, there was the Sendai framework for disaster risk reduction, a policy paper developed at the same time as the Sustainable Development Goals. And so there are processes in train for the world to collaborate increasingly to protect ourselves, but it does need sustained investment. And this sort of panic and then forget cycle that has been mentioned is one we do need to overcome. But it also requires strong and sustained investment in health systems and an expansion of universal health coverage. Because one of the biggest bits of learning, and it's not so much for the UK, but for the rest of the world, is that the people who have suffered most from the pandemic have been those who haven't had access to basic health services or who have had comorbidities and other diseases. And we need to ensure that all of those things are addressed, and we don't just deal with the pandemic threat, but we deal with the broad range of health problems that face populations.
Okay, I think we have time for one more quick question. Dr. Jamila, can I ask you, if you could answer briefly for us, what needs to be done to ensure that the world, particularly the emerging world, is better protected in the event of another pandemic in the future?
I think it's a matter of when and not if that we have another shock to our health systems or even our country. And I think that we need to have a multi-hazard, multi-system approach to managing risk. We also have to look at the underlying causes of why so many of these risks arise. And I think we have to acknowledge that our planetary health boundaries have been violated. There's been a lot of environmental factors that have also contributed to why we are in this situation now, whether it's flooding or the whole impact of climate change and so on and so forth. So I think it needs us to look at a much broader perspective on health and risk. And I think we have to put much more of a futures and foresight lens as well and collaborate.
Okay, and Professor McLaws, really quickly now, do you believe that we will be learning these lessons and that they will be applied by both the developing and the developed world?
Because we've had such, in true terms, pandemic, I can't imagine that the Western world will ignore this opportunity, and we will get together as a global community and learn how best to prepare, because when we add climate change, this pandemic will look like just a trial run. So yes, I believe we won't squander this opportunity.
Okay, some wise words and hopeful words to end this discussion on. I'd like to thank all of our guests for being with us on this session at the TRT World Forum 2020. Thank you to Dr. Mehmet Oz, Dr. Neil Squires, Dr. Jamila Mahmood, Professor Eskild Peterson, and Professor Mary Louise McLaws. And thank you to you all who've tuned into this session. I hope you found it as interesting and informative as I have. Okay. It is now my pleasure to introduce a very special performance by the Turkish composer and pianist Angelika Akbar. Ms. Akbar could play the piano and read music before reaching the age of 3, and she has more than 500 compositions for the symphonic and chamber orchestras. She has also released 14 albums, including the first solo adaptation of Vivaldi's Four Seasons, violin concertos under the Sony Music International label, and the